Hello, let me just share my slides. Alright. So good evening, everyone. My topic for tonight is timely since recently I have been having several referrals for caustic ingestion. In fact, after this recording, I will go straight to one of the hospitals here in Cagayan de Oro to do endoscopy on a teenager who just ingested muriatic acid after her mom scolded her for not slicing the onions well. Right? So I have had my fair share of caustic ingestion patients, and mostly I've sent home well, but some having severe complications and even some dying. And it is sad to see that those surviving with severe complications would have their young lives changed forever. The caustic comes from the ancient Greek word caustikos or costos, meaning burn, and the Latin word causticos, meaning burning. So the burning sensation is felt by patients as there is chemical tissue injury, as the caustic substance makes contact with tissues in the mouth, esophagus, and stomach. Traditionally, when we say caustic, we mean alkaline, and when we say corrosive, acid. But nowadays, these two are oftentimes used interchangeably. Most caustic ingestions happen at home. Young children ingest by accident, and most teenagers ingest intentionally. In the Philippines, we have around 50 admissions per year, and up to half of these patients will have esophageal injury. But fortunately, most will just have minor burns. Caustics are categorized based on their pH into acids, bases, and oxidants or neutrals. Our blood's pH is between 7.35 to 7.45. Water has a pH of 7. Our usual colas or sodas is at pH 3, and our gastric acid is between 1 to 2. Ammonia is on the other end of the spectrum, and it has a pH of 12. Oxidants would include your household bleaches, your agua oxinada, and your betadine solution. And they have a pH between 2 and 12, and they only produce minor burns. But if ingested in large amounts, they may cause severe injuries. Strong acids would include your muriatic acid, your sulfuric acid from battery fluid and jewelry cleaners, carboxylic and hydrochloric acid from your toilet bowl cleaners, your oxalic and glycolic acid from your metal cleaners, and they have a pH of 2 or less. Strong alkali would have a pH of 12 up, and they include your liquid sosa, lye, ammonia, and hair relaxers. Alkali produce liquefactive necrosis by hydrolyzing fat tissue into salts. They taste bitter, and damage is usually seen proximal in the esophagus. Acids, on the other hand, cause coagulation of tissue proteins, and burns are usually not deep because of the tendency of forming eschar, and the esophagus is naturally spared because it is resistant to acid, and thus injury is more distal, located at the stomach. Several factors will determine the severity of caustic injury. Solid or powder preparations will have longer contact time with the tissues compared to liquids. They will have deeper and more proximal damage. The more amount ingested, the bigger the damage. Large ingested volumes are seen in intentional and alkali ingestions. Industrial grade solvents produce greater injuries because they are more concentrated and they have stronger and they are stronger acids or bases compared to their household counterparts. After the initial necrosis, tissue inflammation and thrombus formation follows. Granulation begins on the second week post-ingestion. There is increased risk of perforation as there is thinning of the esophageal wall. Fibrosis starts on the third week, followed by stricture formation and deformity, uh, usually completed around day 30 to 45. Symptoms of caustic ingestion will include drooling, dysphagia, vomiting, chest pain, and abdominal pain. One may also see oral burns, noisy breathing. The abdomen of the victim may be painful to touch, and the child may look pale and even may be found unconscious. Parents and caregivers are the usual first responders. As with all emergency, it is important to first assess the scene. Make sure that uh, the child and the rescuer is safe, and it is also important to bring the child to a safe corner where the child can be checked better. Check airway, breathing, and circulation and give the appropriate response. Have someone call for help. The National Poison Control Center can give initial advice on what to do. Call 911 or someone to bring the child to the nearest hospital for better assessment. While waiting for help to come, it is important to remove clothing that are contaminated. Wash and wipe away chemicals on the skin with soap and running water. Chemicals on the eye can be washed with running water. It's also important for caregivers to do no further damage. So do not induce vomiting or feed the child or give any medications before the patient is brought to the emergency room. Parents must also take note of the time of ingestion and, as possible, bring the substance or any identical preparation or product of the ingested substance and go to the nearest hospital. So at the ER, airway obstruction is the immediate life-threatening complication, and it is important that physicians identify this. Patients with airway obstruction will present with hoarseness, drooling, dyspnea, noisy breathing, and desaturations. Intubation may be required in around 12% of children and 50% of adults. And airway injury may be due to the initial contact of the caustic substance, but oftentimes it is also due to re-exposure of the airway tissues during induced vomiting. Your macular triad of vomiting, chest pain, and sub-Q emphysema, and your Anderson's triad of abdominal rigidity, tachypnea, and sub-Q emphysema may point out to an esophageal perforation. Severe abdominal pain and hematemesis and an acute abdomen and sometimes hypotension may signify gastric perforation. So any suspicion of perforation requires confirmatory testing and diagnostics, and also early referral to surgery. The Philippine Society for Pediatric Gastroenterology, Hepatology, and Nutrition uh, came up with a policy statement on caustic ingestions. And in this policy statement, uh, the signs and symptoms are categorized into minor or major or red flag signs. And any two minor signs and symptoms require referral to a pediatric gastroenterologist for possible endoscopy. And any major sign require referral to both your pedia GI and your pedia surgeon. It is also important to determine the pH of the caustic ingested, especially if the substance is not commercially prepared or was transferred to another container. Except for neutrophilic leukocytosis and metabolic acidosis, your blood tests do not predict severity of caustic injury. But these tests may help point out complications and existing comorbidities. A chest X-ray can be useful in ruling out aspiration pneumonitis and your esophageal or gastric perforation. A CT scan may be required in unstable patients who cannot undergo endoscopy. It is also useful to evaluate the depth and extent of burns, and also to look for subtle signs of perforation. There is also a CT grading for caustic ingestion. Grade 4 may signify perforation, where you have blurring of your esophageal lumen and tissues on CT scan. It is also recommended for patients with severe caustic injury seen in endoscopy to undergo CT scan so that we may screen better patients requiring surgery for deep tissue injury. In the ER, do not attempt to insert NGT blindly because you risk esophageal perforation. Activated charcoal aren't that useful for caustic ingestion, and this will also block proper visualization of your injured tissues during endoscopy. The giving of weak acids or bases to neutralize the caustic ingested will cause more damage due to thermal reactions. And giving of water or milk to dilute the caustic may trigger vomiting and also reflux of the caustic back up. So we don't want that. So this is algorithm coming from the PS Pagan policy statement, and this provides a guide for decision making on what to do for caustic patients. So we advise admission for all caustic ingestion patients for evaluation and management, and also for observation. If the caustic is your household bleach or your sodium hypochlorite, or if the caustic ingestion is not definite, we can do trial feeding with clear liquids and observe for 24 hours. And if the patient is asymptomatic, we can discharge these patients. We advise the patient to come back immediately if there are unwanted signs and symptoms that may develop later on. And also, the risk of strictures is low, no, in this patients who ingested your neutrals or your oxidants. An upper GI series is recommended if dysphagia develops later on. If the caustic ingestion is definite, we take note of the presence of drooling and other signs and symptoms, your minor and your major signs. If there is only one minor sign and symptom, we can start clear liquids and absorb. If the initial feeding is not tolerated, then we refer the patient immediately for endoscopy. If there is drooling or there are two or more signs and symptoms, uh, we do not feed the patient and refer immediately to your pedia GI for endoscopy. Any severe sign and symptoms warrant referral to both your pedia GI and your pedia surgeon. And we will be the ones to decide whether endoscopy or immediate surgery is the next step for these patients. So there are different classifications for caustic injuries seen on endoscopy, but the more popularly used classification is your Zargar scoring. Grade 0 means no injury. Grade 1 are those with erythema and edema. The presence of erosions, hemorrhage, and ulcers signify grade 2 injury. If these lesions are isolated, it is classified as 2A, and 2B if the lesions are circumferential. Deep focal ulcers and eschar formation are classified as grade 3 injury, and 3B if these eschars and ulcers are extensive. Grade 4 signifies perforation. Zargar grading predicts stricture formation and prognosis for these patients. Stricture formation is expected in circumferential lesions as well if the ulcers are deep. And there is also high risk for mortality in patients with perforation. So after endoscopy, patients with grade 0 or 1 Zargar score may have diet as tolerated and may be sent home. Patients with superficial, isolated, or focal lesions or Zargar grade 2A injury seen on endoscopy may have a trial of soft diet post-endoscopy and will also benefit with short course of acid suppression. And then these patients may be sent home if the diet is tolerated. Those with grade 2B and up will need to be placed on NPO, ideally for 2 weeks. TPN for 2 weeks is expensive and we will have a lot of complications. What we practice here in the Philippines is to refer these patients immediately to your pedia surgeons for either G-tube insertion if there are no gastric injury seen, or J-tube insertion if there is gastric injury seen on endoscopy. This algorithm was recently published 2020 in the New England Journal of Medicine. Here is decision making. It relies whether the caustic ingested is acid or alkali. And then endoscopy is recommended for all acid ingestions. And endoscopy injury grading determines whether the management for these patients will be. And the management is more or less similar to the PSPAGAT algorithm. For unintentional alkali ingestion, asymptomatic patients are fed and observed up to 6 hours and discharged if diet is tolerated. If these patients have drooling, vomiting, or is unable to eat during the trial feeding, they are placed on NPO overnight, and then trial feeding is again resumed. So endoscopy is recommended if these patients are not able to drink or on the second resumption of feeding, and if these patients have stridor or both vomiting and drooling at the onset. For intentional alkali ingestion, endoscopy is always recommended. Patients with severe caustic injury are at risk for malnutrition. It is important that they are referred early to surgery for tube feeding. For patients needing endoscopic assessment but are unable to do endoscopy because of either late referral. So we want to do endoscopy before 72 hours so that we avoid having perforation, no, or iatrogenic perforation because of the endoscopy. And also if there is an unavailable uh, endoscopy machines in the area or the endoscopist is not available, and also if there are if this is due to financial constraints. So the usual practice for these patients who was not able to undergo endoscopy is to refer these patients for J-tube insertion uh, to your by your surgeons, no? And to start jejunostomy feeding for at least a month. And it is only after a month where we could do upper GI series and an endoscopy for evaluation. Some authors would attempt per RM feeding, no, in patients that can swallow their saliva and proceed to your total parenteral nutrition or tube feeding if the trial is unsuccessful. Whether or not steroids will prevent strictures is still debatable. The risk of infection is one reason why a lot of pediatric gastroenterologists shy away from using steroids. I can remember two of my patients with grade 2 2B esophageal injury. The first was due to liquid salsa ingestion, and in this patient, I did not give steroids. Uh, the patient eventually developed multiple tight esophageal strictures, no, on follow-up endoscopy. And after 6 years, no, this patient is still on gastrostomy tube feeding, awaiting for financial capacity to afford your MRI, neck MRI. Uh, the second patient was a toilet drain powder ingestion I saw around a couple of months ago. And this time I gave a week uh, course of dexamethasone. Uh, on repeat endoscopy, the patient still developed esophageal strictures, but in this patient, uh, there was enough patency, no, of the stricture to allow oral food intake. So I guess there's some benefit when giving when you give steroids, no, for severe caustic injury. Antibiotics should be given only for severe caustic injuries and only if there is aspiration pneumonitis or when we plan to use steroids on our patients. There are several promising anti-stricture medications like your sucralfate, mitomycin, and triamcinolone injections during stricture dilatation. Also, vitamin E and your ketotifen, no, are some of your anti-stricture medications being studied right now. So we will have to wait for bigger studies, you know, before we can recommend them as routine in patients with severe caustic injury. The thing is that the dread of caustic ingestions are the complications. Uh, Skin and eye injuries may present initially, no, in some of these patients. Aspiration, pneumonitis, and perforations, no, may lead to respiratory failure. Some caustics, like your hydrofluoric acid, will have toxic effects, no, and you will have systemic complications. So it is also wise to refer our caustic patients to our toxicologist. Severe caustic burns may also cause GI bleeding, perforation, and even pancreatitis on some pediatric patients. If it ain't bad enough for these patients during the first week. They are also at risk of developing late complications like your strictures, your esophageal dysfunction, uh, in the coming weeks. So surveillance is also needed because these patients with severe caustic injury are at risk to develop malignancy, especially your esophageal squamous cell carcinoma and adenocarcinoma uh, decades later. At the ER, so it's important to detect perforation. Esophageal perforation are more common in alkali ingestions and gastric perforation in acid ingestions. So for esophageal perforations, in children, we would want to have a more conservative management because esophageal transposition later on in these patients is difficult, and these patients uh, will have poor quality of life when we do aggressive resection. Surgery on perforated sites will also be sites for future strictures. Strictures are expected and dreaded complications for severe caustic injuries, and they develop starting at the third week, but completion may take more than a month. Esophageal strictures may present as dysphagia and even the inability to drink or choking if the stricture is tight. Vomiting is more commonly seen in gastric strictures. So it is routine that we do barium swallow or upper GI series after a month uh, after a month post ingestion before we do an endoscopy. The specific treatment therapy used for significant caustic esophagitis seem to have less influence, on the development of stricture formation. So compared to the degree of injury immediately after ingestion. So it's more of the severity of injury rather than the management for this injury that will predict stricture formation. And the use of antibiotics up to now remains controversial, on the prevention of stricture. To date, there is still insufficient data recommending the use of high dose steroids to prevent formation of strictures. Stents have been used with variable degrees of success, and these stents are believed to inhibit excessive granuloma formation and provide early continuous dilatation. However, tolerance to these inserted stents, and also a lot of associated complications limit the use as of now for stents in children. So it is said that dilatation is best started once stricture is developing. Some authors say early as 2 weeks. However, the general consensus for now is to start uh, at least a month post ingestion, and it is usually performed antegrade, via balloon or rigid dilators. It can also be performed retrograde through a gastrostomy tube. Balloon dilators are the more commonly used ones, and these dilators give equal and radial dilating force, and it is preferred because it is less traumatic compared to the blunt, or blunt dilators like your Savary bougies. These dilators will provide uh, axial and radial shearing forces, uh, but these dilators are associated with more complications, and more trauma. Dilating sessions are done at least once or twice a month until the child can tolerate oral feeding. And recurrence of strictures are quite high, and the need for continuous dilatation uh, for more than a year, no, is an indication for esophageal surgery, because we considered this as dilatation failure. Contraindications for dilatation, no, are multiple strictures, strictures more than 5 centimeters, or if there is tortuous deformity due to your caustic injury. So you have here your balloon dilators and your rigid or your Savary dilator. And the goal really for dilation, no, is to provide enough opening, no, to allow oral food intake. So in children, it is well established that preserving your native esophagus is the ideal option. Esophageal replacement is considered only in cases of failure to establish oral feeding more than 6 months, and also if there is nutritional, social, psychological, uh, and domestic problems arising due to the strictures. Resection can be done only in solitary and short strictures. So colonic transposition is the more commonly done procedure for esophageal replacement. The procedure is difficult and complication rates are high. During my training, I had two patients who underwent esophageal replacement surgery, and all these two patients did not survive. Abroad, there is an increasing trend on doing gastric interposition rather than the colonic transposition, because this procedure is less complicated and just will have fewer complications. So for caustic ingestion, prevention is gold. Caustic agents at home should be kept inaccessible to children, up and away. It is also advised to avoid transferring caustics to another container, especially empty water bottles. So I have had a few teenagers, no, accidentally ingesting caustics transferred to mineral water bottles placed on the ref, no, and even some placed on fruit juices containers, no. So cause a lot of problems, no, when accidentally ingested. And we also wish for a stricter enforcement of your child resistant containers for caustic substances by the government. It is the role for both government and for us physicians, no, to spread awareness, uh, of the dangers of caustic ingestion. And that is why I am discussing ingestion and injury tonight. So caustic ingestion and injury in children is something that needs to be prevented. Severe injury and even death can happen. And those that survive the first few weeks of severe caustic injury will continue to suffer from debilitating complications, possibly a lifetime. So it breaks my heart knowing that these kids having uh, severe caustic injury, no, will have their lives changed forever because of one unfortunate incident. And unfortunately, there is no rewind button for these kids. So with that, I end my lecture. Thank you for your attention and good evening.